So the topic for today is episiotomy. It will be an OSPE. You have to demonstrate how to do it, and you have to demonstrate how to repair the OSPE episiotomy. Okay. What's an episiotomy? On the surgically planned incision on where? On the perineum to facilitate the delivery of the fetal presenting part. Okay. Episiotomy is a surgically planned incision given on the perineum to facilitate the delivery of the fetal presenting part. The perineum looks somewhat like this. Okay, this is what a perineum looks like. Episiotomy at what stage of labor is it given? Sorry?
Third stage.
What is the third stage? What is the third stage? তার মধ্যে আমার এপিসোডমি লাগবে বাচ্চা তো বেরিয়ে গেছে অলরেডি so it is given at late second stage of labor. The term is late second stage of labor after crowning of the fetal presenting part. What is crowning? In the absence of contraction, when the fetal presenting part, from now on we are going to focus on saying presenting part and not head, because the presenting part may be breech also. Okay, we are going to practice saying the fetal presenting part. Crowning is when the fetal presenting part is visible in the introitus without separating the introitus irrespective of uterine contractions. মানে relaxation stage of presenting part ta visible আছে, that is called crowning. We give the episiotomy at the stage of crowning, that is late second stage of labor. Okay, what are the prerequisites for giving an episiotomy? কি কি আমাদের করতে হবে আগে? Type of anesthesia, local, given by infiltration of 1% lidocaine hydrochloride. ঠিক আছে, তার আগে কিছু করতে হবে? Consent. Very good. Since you are going to be demonstrating the episiotomy, you have to mention that you are going to get a consent from the patient. Okay, you're going to get a verbal consent because at the height of labor it's not very feasible to get a written consent. We are going to get a verbal consent of the patient for the episiotomy. We are going to cleanse the perineum with an antiseptic solution, betadine. We're going to cleanse it with it. Ideally, you should drape the place with a cut sheet. Then we are going to give the episiotomy. Okay. How? This is the instrument that is used for giving an episiotomy. This is known as an episiotomy scissors. Okay. This scissors is kind of curved. Can you see? Even if I closed it, it's not a straight scissors. It's a curved scissors. So this is an episiotomy scissors. It's curved. It has two kinds of blade. One has a blunt end, the other one has a sharp end. This blunt end will go inside the vagina. The sharp end will stay outside of it in order to prevent injury to the fetal head presenting part. Okay. So now, what are the types of episiotomy?
Median, mediolateral, lateral.
Median, mediolateral and lateral. What at a J shaped bole? Yes. What kind of episiotomy do we prefer to give?
Mediolateral.
Mediolateral. Why? Any episiotomy is basically a perineal tear. Okay. Any episiotomy is a perineal tear. We have 4 grades of perineal tear. Grade 1 to grade 4. Okay. হ্যাঁ, মানে আমরা we are trying to prevent grade 3 and grade 4 kinds of perineal tear. Any kind of normal episiotomy is either a grade 1 or a grade 2 tear. We are going to talk about the grades. Any kind of episiotomy is either a grade 1, more commonly a grade 2 kind of perineal tear. So if we are saying to avoid perineal tear, we have to mention that we are trying to avoid grade 4 and grade 3 kinds of perineal tears. Okay. Acha, কি বলছিলাম, why the mediolateral? Anything else?
Right side and mainly preferred.
Why?
ওইদিকে নার্ভটাকে
Left side এর nerve থাকে না?
সরি ওএসএসটাকে প্রিভেন্ট করতে হবে। Obstructive anal sphincter injuries.
What is OSS?
Obstructive anal sphincter.
Obstetric anal sphincter injury syndrome. বাদিকে কাটলে হবে না? Anal sphincter কি বাদিক ডান দিকে আলাদা আছে? তাহলে why do you prefer to give it on the right side? Yes, because most of us are right-handed. That's why. Simple thing. Most of us are right-handed, right dominant. That's why we are giving it on the right side. As simple as that. Okay. There's the other school of thought that says that since the sigmoid is closed on the left side, but sigmoid অনেক উপরে আছে. You cannot cut to the sigmoid even if you try your level best. Okay. The answer is because most of us are right dominant, we are giving it on the right hand side. If you are left dominant, you are going to give it on the left hand side. Am I clear? Okay. Achha, what are the advantage of mediolateral and what is the disadvantage of mediolateral episiotomy? Firstly, at the জিনিস দেখে নাও. This is what a mediolateral episiotomy looks like. See, this is the upper part, the urethra. This is the fourchette. We're giving it on the lateral side, mediolateral. Okay, an oblique shaped incision হবে. It's visible. Differentiate this from this. This is a median episiotomy. Okay, can you differentiate the two? Okay. So we are going to prefer the mediolateral in order to prevent excessive extension of this tear and going into 3rd and 4th degrees of perineal tears. We are going to allow this kind of episiotomy. But for repair wise, repair করার ease, amount of blood loss, সবকিছুর জন্য advantage হচ্ছে median episiotomy. This bleeds less, this has better apposition ability, and this is easier to repair. But still we prefer to go for a mediolateral episiotomy in order to prevent external anal sphincter and internal anal sphincter injuries. Okay? আচ্ছা, বললাম advantage and disadvantage. আচ্ছা, টাইপ কি করে করব প্রসিডিউরে আমরা ফার্স্টলি বললাম যে we are going to take a patient's consent, draping and dressing, antiseptic washing, draping, dressing. Then we are going to infiltrate this part in a fan shaped manner. Infiltration of the perineum in a fan shaped manner. Fan shaped manner মানে spread করে, মানে আমি যদি if I plan my incision along this line, it's not necessary that I'm going to infiltrate only along this line. A little above it, a little below it, and on the line. We are going to infiltrate all these parts. That's why it's called a fan shaped infiltration. Okay. Then we are going to put this is going to be stayed like this. I'm going to put 2 fingers of my non-dominant hand. My non-dominant hand is my left hand. I'm going to put 2 fingers of my non-dominant hand into the vagina, in between the fetal presenting part and the vaginal wall. The palmar surface of my hand is going to face the vagina, like this. Okay. Next, we are going to insert this one. These 2 fingers are going to be my guard against the blade hitting the fetal presenting part. So, like this. The nick should be done judiciously, small, and preferably at the height of the uterine contraction. Preferably at the height of uterine contraction. Why? Yes, because at the height of the uterine contraction, your presenting part is stretching the perineum and it is the thinnest possible perineum. So you're going to cut through less structures and you're going to injure less structure. That is why আমরা বলি ক্রাউনিং হয়ে যাওয়ার পরে পেরিনিয়াম যখন thinned out হয়ে যাচ্ছে, at the verge of expulsion, একটু বেশি দেরি হয়ে গেল না? চলে at the verge of same batch না আসবে না? আচ্ছা, at the verge of expulsion of the fetal presenting part, that is the point we are going to give the incision because the perineum is stretched out at that point. Okay. What are the structures that you cut while giving an episiotomy? That is the point. Muscles. Muscles is a very big term. What muscle are you cutting?
Perineal muscles.
Naam. I'm asking for the names. Tell me the structures that are... Sit down. Tell me the structures that are cut while giving an episiotomy. Skin, subcutaneous fat. After that. That is common for everybody. Then? Where is levator ani? কটা পার্ট আছে levator ani? কি কি? তাই? Pubococcyges, iliococcyges and puborectalis. Ischiococcygis বলে কোনো মাসল হয় না, ঠিক আছে? আচ্ছা, What are we cutting? What are the muscles that we are cutting? Number 1, superficial transverse perineal muscle. Superficial transverse perineal muscle. Number 2, bulbospongiosus. What is the bulbospongiosus? Which part is, it's not part of levator ani. Which part is the bulbospongiosus? Nah. This part is the bulbospongiosus. This part that makes this part spongy. কি বলে লেবিয়া মেজোরার ভিতরে যে মাসলটা থাকে, that is called bulbospongiosus. Okay? কি বললাম? Superficial transverse perineal muscle, bulbospongiosus, deep transverse perineal muscle. Some fibers of the levator ani. We do not know which fibers exactly, but some fibers of the levator ani, and then the vaginal mucosa. So কি কাটলাম আমরা? Skin, subcutaneous fat, superficial transverse perineal muscle, bulbospongiosus, deep transverse perineal muscle, levator ani, vaginal mucosa. This is from outside to inwards. উল্টো বললে from inside to outwards. ঠিক আছে? এরকম করে মেনশন করতে হবে. If your cut is extended or a tear is extended into a 3rd or 4th degree tears, what are the other muscles that you have cut? External anal sphincter and the internal anal sphincter. আর যদি 4th degree হয়ে যায় তার মানে কি কাটছি? কি কনফিউশন হলো? We have basically 4 degrees of perineal tears. 4 degrees of perineal tears. First degree মানে হচ্ছে either only the perineal skin or the vaginal mucosa. Either of the two is cut. ভিতর দিক থেকে mucosa কেটেছে বা বাইরের দিক থেকে skin কেটেছে. This is called a degree 1, মানে first degree perineal tear. Second degree perineal tear মানে হচ্ছে episiotomy, যেটা বললাম, যা যা মাসল কাটছে এটাকে বলে second degree perineal tear. Third degree perineal tear মানে হচ্ছে along with the episiotomy muscles we have cut the external anal sphincter and or the internal anal sphincter. Okay? And 4th degree of perineal tear মানে হচ্ছে you have cut the rectal or anal mucosa. There is a continuous opening between the vagina and the rectum. This is called a 4th degree of perineal tear. এর মধ্যে যে 3rd ডিগ্রিটা বললাম, এই 3rd ডিগ্রির মধ্যে তিনটে পার্ট আছে, 3A, 3B and 3C. 3A মানে হচ্ছে less than 50% of the external sphincter কাটা গেছে, 3B মানে হচ্ছে more than 50% external sphincter, and 3C মানে হচ্ছে internal anal sphincter কাটা গেছে. বুঝতে পারলাম কি বলছি? So we have 4 degrees of perineal tears. Right now we are concerned with the 2nd degree. কি মাসল কাটলাম বললাম আমরা? বেশ. What the complications of episiotomy? Valval hematoma হতে পারে, আর কিছু? wound infection হতে পারে, আর কিছু? What can be the complications of episiotomy wound? First complication হচ্ছে bleeding. It may lead to traumatic postpartum hemorrhage. Excessive bleeding হচ্ছে, excessive tear হয়েছে, it's bleeding profusely, it's going to cause hemorrhage. Number 1. Number 2, after repair যদি আমি bleeding বন্ধ না করতে পারি, it can cause valval hematomas. Valval hematomas basically আমরা যখন এটাকে এই woundটা বন্ধ করে দিয়েছি, কিন্তু তার ভিতরে ব্লিডিং হওয়া কন্টিনিউয়াস হয়ে যাচ্ছে, তো ব্লিডিং ইজ অ্যাকিউমুলেটিং ইন বিটুইন দ্য লেয়ার্স অফ মাই রিপেয়ার. পেরিনিয়ামটা এরকম করে swelling up শুরু হবে, অ্যাকিউট পেন, মোস্ট কমন, এটা এমসিকিউ যে জিজ্ঞেস করবে বা ভাইভাতে জিজ্ঞেস করবে, what does a patient of valval hematoma present to you with? What is the first symptom of valval hematoma? No. Yes, a valval hematoma presents with urinary retention. Pain যে কোনো এপিসোডমিতে হবে. Pain will not be determining factor. The patient will come to the clinic or patient will complain to the ward in charge that she is having urinary retention. That will be your first sign. I have to examine this patient. She might have a valval hematoma. Okay? Hematoma holo, pain holo, কি বললাম, ইনফেকশন হলো, সেপসিস হতে পারে, পেরিয়াপিডাল সেপসিস হতে পারে, ইনফেকশন হতে পারে, wound dehiscence হতে পারে, খুলে যেতে পারে wound. Long term complication, there may be dyspareunia, there may be something called as scar endometriosis. What is scar endometriosis? Implantation of the uterine endometrium into the episiotomy scar, causing something called as scar endometriosis. না, স্কার প্রেগনেন্সি সামথিং এলস। স্কার প্রেগনেন্সি মানে সিজারিয়ান স্কারের মধ্যে প্রেগনেন্সি ইমপ্ল্যান্ট হয়েছে। This is endometriosis, not pregnancy. Presence of any kind of endometrial glands and stroma outside the endometrial cavity is known as endometriosis. So when it is implanted into this episiotomy scar, it is called as scar endometriosis. একটা বললাম dysperineia, একটা বললাম scar endometriosis. Number 3 কি বললাম? Rigid perineum. Repair হয়েছে, fibrosis হয়েছে, the perineum has become rigid. Further delivery সময় you might require a cesarean section. এমনও হয়েছে। Okay? These are long-term complications. আচ্ছা, repair. We are going to talk about the repair. How do you repair the episiotomy wound? কি কি লেয়ারে রিপেয়ার করব?
ভাজিনাল মিউকোসা, তারপরে মাসল, তারপরে স্কিন, এটাকে
কি দিয়ে করব রিপেয়ার?
ক্যাটকাট,
preferably a vicryl, either a 20 or a 10 vicryl, preferably undyed vicryl, rapid vicryl, but আমরা একটু খরচা, আমরা গরিব দেশ তো we are going to do it with a catgut, chromic catgut, ঠিক আছে? So how? First layer is the vaginal mucosa. We are going to look for the apex. The apex of the wound is somewhere around here. This is the apex of the wound. যেখানে wound শেষ হয়েছে. We're going to go 1 centimeter above the apex. My first bite will be 1 centimeter above the apex. I'm going to cover the mucosa in a continuous non-locking fashion. I'm going to come and cover the mucosa. First layer. Second layer, I'm going to give the muscles. First layer ta bondo hoye gele, it will look something like this. Okay? This muscles, this perineal muscles, we are going to repair by interrupted vicryl sutures or interrupted catgut sutures. And একটা bite দেবো, deep superficial bites in order to close the space. And finally, on the skin, you're going to give mattress sutures or subcuticular sutures. This is how you repair. Mattress or subcuticular sutures. কোনটা কিরম দেখতে হয় জেনে লাভ নেই, just know the names. That's good enough for you. Once when you do it, you're going to know. এবার তোমাকে যখন, this is all about episiotomy. পরীক্ষা যেটা জিজ্ঞেস করবে, it will be an OSPI case. এগুলো শর্ট নোট আসতে পারে বা কিছু লং কোয়েশ্চেনে আসলো। OSPI তে বলবে show me an episiotomy. How you are going to give the episiotomy, how you are going to repair it. আর এডকমে বলবে how you are going to counsel the patient regarding episiotomy. So first thing first, you're going to do is you're going to place it in front of you, this model of the perineum. You're going to demonstrate to the examiner that you're going to take a consent to the patient. Then you're going to drape the place, clean the place. You're going to infiltrate lignocaine. Then you're going to wait till the height of contraction. Then you're going to give a nick around 2 to 3 centimeters of incision in a mediolateral direction. You're going to incise. Then you're going to deliver the fetal presenting part of the fetal head carefully after giving proper guard on the perineum and the urethra. Guard গুলো দিয়ে যাতে excessive tear না হয় সেই জন্য। You're going to give guards by 2 pieces of gauze, one here and one here. Once the fetal head, যে হেডটা যখন বেরোচ্ছে, একটা গজ পিস এখানে গার্ড দেবো, একটা গজ পিস ওপরে গার্ড দেবো, যাতে এগুলোতে টিয়ার না হয়। I'm protecting these parts. করে হেডটা ডেলিভার করবো। দেন যেরকম করে ফিটাল বডি পার্ট ডেলিভার করে, ল্যাটারাল ফ্লেকশনে হাত বের করে, নেক থেকে বের করে রিফ্লেকশন করে বডিটা বের করে দিন। ওকে? কেন? দুটো হাত আছে দুটো। বাচ্চার মাথা বেরোনো অবধি থাকবে, তারপর তো মাথা বেরিয়ে গেলে একটু টিয়ার হয়। প্রেজেন্টিং পার্ট যা টিয়ার করবে, প্রেজেন্টিং পার্ট করবে, তারপরে আর কোনোদিন টিয়ার করবে না। সেটা হেড হোক কি ব্রিচ হোক, দিস ইজ গোয়িং টু গিভ ইউ দ্য টিয়ার। একবার সেটা বেরিয়ে গেলে বাকি কোনো জিনিসে টিয়ার হবে না, আনলেস অ্যান্ড আনটিল ইউ গেট সামথিং কল্ড এ শোল্ডার ডিস্টোসিয়া। If there is shoulder dystocia, which is very rare, if you get a shoulder dystocia case, then the shoulder, you may need to extend your incision. There may be excessive tears while delivering the shoulder. Otherwise, একবার presenting part বেরিয়ে গেলে আর কোনো সময় টিয়ার হবে না। Okay? When are you going to repair this? Repair কখন স্টার্ট করবো আমরা? After delivering of the placenta, I'm going to start my repair. I'm going to examine the entire vulva for any other tear other than my planned incision. Then I'm going to repair them. Okay? Prophylactic Foley's catheterization is not necessary. আচ্ছা, এটা কি বলছিলাম? আচ্ছা, the current school of thought says that you do not need Compulsory episiotomy for all patients are not required. It is said that you have to do judicious use of episiotomy. আগেকার দিনে বলা হতো যে বাচ্চা বেরোবে, টিয়ার হবে, টিয়ারের থেকে প্ল্যান্ড ইনসিশন ইজ বেটার। টিয়ারটা র্যাগেড এজেস হবে, রিপেয়ার করা ডিফিকাল্ট হবে, এক্সেসিভ টিয়ার হলো, কি ছিড়বে না ছিড়বে, কি রিপেয়ার করবো আমরা। সো earlier we used to think that giving an episiotomy is better than having a tear. We used to think that. Okay. Current based guidelines are saying that episiotomies should be used judiciously, considering the baby is big, macrosomia ache, there is rigid perineum, you're going to use an instrument for delivery, মানে forceps or ventouse instrumental delivery হচ্ছে, বা you have to cut short the second stage of labor in cases of fetal distress, or in cases of whether it's maternal কোনো hypertension বা maternal cardiac disease, heart disease কিছু আছে, where you require cutting short the second stage of labor, only then you use an episiotomy. Otherwise you let the perineum stretch. এখন বলা হয় যে even small perineal tears are better than episiotomy wounds. They heal faster, they heal naturally, and they cause less post-operative pain. ঠিক আছে? But for your levels, you're going to say you're going to give episiotomy for primary gravida mothers. First pregnancies, first deliveries, we are going to give episiotomy before delivering the head. You're going to say that in your examinations. When you're practicing in your internship, you should always wait for the judicious use. একদম বাচ্চা দেখতে পেলাম কেটে দিলাম সেরকম হবে না। You're going to wait, you're going to let the perineum stretch. Even after that, if you think the perineum is not adequate, only then you give an episiotomy. কি বলছি ক্লিয়ার হচ্ছে? It's not mandatory to give an episiotomy for all first deliveries. Second, third এর তো ছেড়েই দেয়, it's not necessary at all. First delivery though, it's not necessary always. The baby may deliver on its own also if you give proper guard and proper flexion. ঠিক আছে? বলো, questions? The counseling would be something like this, that your baby's head or the baby's presenting part looks a little bigger than your perineum is stretching. I'm going to give an incision. It's not going to be painful at this time, but later on you might experience some amount of pain. You might experience some amount of urinary discomfort, some amount of dyspareunia afterwards. You're going to, this is the procedure of cleaning this. How do you, okay, we're going to talk about how to clean it. Sorry, I forgot that. You're going to explain to the patient how to clean this area, how to keep it neat and clean so that she doesn't get it infected. You're going to explain to her that these stitches will not require removal later on. They will absorb on their own, and it will leave minimal to no scarring if it heals properly. Acha. Post discharge advice. Once you have given the episiotomy, you have repaired the episiotomy, you have discharged this patient on day 2 or day 3. What advice will you give to the patient for maintaining this episiotomy wound? What advice will you give?
স্ট্রেনিং করা,
Huh?
স্ট্রেনিং, প্রিভেন্ট স্ট্রেনিং।
ঠিক আছে, prevent training. What advice will you give? Any kind of weightlifting, any kind of sexual intercourse is avoided for at least 3 to 6 months. What a routine for any kind of vaginal deliveries. You're going to advise her that you clean the episiotomy wound with a disinfectant, preferably povidone iodine, every time after she goes for urination or defecation. You're going to clean it. Okay, number 1. Number 2, you're going to advise her a sitz bath. You understand the sitz bath? You're going to advise her a sitz bath. In India, we give prophylactic antibiotics. Outside dawa hai na, kintu we are going to give one course of antibiotics for all patients of episiotomy. ঠিক আছে? And you're going to ask her to come for a follow-up after 2 to 3 weeks. Okay? Oh, painkiller, sorry. Brufen ho, paracetamol, we're going to give her a painkiller for it. Okay? And to keep the stool soft, you're going to give lactulose. Questions now? আমার পড়ানো শেষ। ভার্বাল কনসেন্ট নিতে হবে। ইটস নট অলওয়েজ পসিবল যে গার্জেনের থেকে কনসেন্ট নেব। ইটস এ পিক অফ দ্য মোমেন্টে কাজ করা না, যে বেরোবে কি বেরোবে না, ইউ ইন ডাউট, ডিলেমা, বেরোচ্ছে না তখন আমি দিচ্ছি। তো ইটস নট পসিবল অলওয়েজ টু গো আউটসাইড এন্ড টেক দ্য কনসেন্ট অফ দ্য গার্জেন অর দ্য পেরেন্টস অর দ্য হাজবেন্ড। ইটস বেটার টু টেক দ্য কনসেন্ট অফ দ্য পেশেন্ট ইন স্ট্যাট যে আমি দেবো স্পট কনসেন্ট। ঠিক আছে? দ্যাটস ওয়াই ইটস এ ভার্বাল কনসেন্ট। বাইরের দেশে যেটা হয় যে ইউ হ্যাভ almost 1-to-1 ratio of doctors and patients, so a family member or a birth assistant বলা হয় তাদেরকে। হ্যাঁ, আমাদের দেশে আস্তে আস্তে কনসেপ্ট আসছে, it's called birth assistants. So the patient who is giving birth, her husband or her mother or mother-in-law, someone is present with her in the labor room and you're delivering that in front of her, so you can take the consent from them also. She's in a better state of mind than the patient to understand, take the consent there. So this concept is coming out. Currently we just take verbal consent. এসছে কিন্তু সেটা এখনো সেরকম ভাবে ইয়ে হয়নি, it's not applicable yet as such. হ্যাঁ, পার্টোগ্রাফ অনেক বছর ধরে আছে, পার্টোগ্রাফ is not new. Partograph has been there from 1987. Simplified. We use the simplified one, not the modified one. Questions? Clean it, seats back. Questions. পরীক্ষায় কিন্তু জিজ্ঞেস করবে, somebody demonstrate to me what you are going to do.
Central to outside
Draping is, vaginal cleaning is not done from central to lateral. It's done from upwards to downwards. This is sterile. The anal orifice is unsterile. All dressing, all cleaning has to be done from up to down. That is for any cases. যখন patient কে clean করতে বলবে, even after going to maturation or defecation, is always উপর থেকে নিচে বা সামনে থেকে পিছনে, not the other way around. ঠিক আছে? চলো নেক্সট করে দেখাতে হবে। এটা অসপি ইনজেকশন নয়, নেই, না, নো হোল্ডিংস, এই ভিতরে চলে যাবে। Your fingers will be inside like this, no holding. Your thumb has no use. Okay? Abar, once more. No. This direction. না, ইনফিল্ট্রেশন হলো, তারপর কাটবি তো, তার আগে গছ পিস কাটবো তো, কাটবি কি করে, ওটা রাখ, ডু ভালো করে ঠিক করে, কোন হাতে, না কোন হাতে ধরে, কি করে ধরে, থাম্ব ব্যান্ড, তাই এতদিনে এই হলো, থাম্ব ব্যান্ড উইচ ফিঙ্গার, তাহলে ইয়েস, ধরা কি ঠিক হলো, কাটতে পারবি এরকম করে, ধরা ঠিক হলো কি, কাটতে পারবি, দেখ নিজে দেখ, ইয়েস, এবার হ্যাঁ, ইনজুরি না হয়, হ্যাঁ, ইনসিশন দিলি, আশেপাশে টিয়ার যাতে না হয় বেশি, ঠিক আছে? Then you are going to deliver the baby. Okay? Prepare somebody else. Chalo.
So for the repair, we have to first look at the apex of the cut. So 1 centimeter above the apex, you have to give the knot. Then
Holo na ব্যাপার,
above the apex,
you are doing a new OSPI.
okay.
She has done her part. You are doing a new OSPI. What's the first step?
আচ্ছা, consent
আর কনসেন্ট কি লাগবে?
আর লাগবে,
কেটেছিস যখন তোকে সেলাই করতেই হবে।
হ্যাঁ স্যার,
ও যদি বলে না সেলাই দেবো না, তো সেলাই দিতে পারিস না, তাই তো? নো কনসেন্ট। ফার্স্ট স্টেপটা কি হবে তাহলে? অ্যান্টিসেপ্টিক ড্রেসিং।
আচ্ছা আচ্ছা,
You are, it's draped, but it has become soiled by everything that has come out from inside. है ना? ব্লাড বেরিয়েছে, এইসব ইয়ে বেরিয়েছে, স্টুল এসছে, জিনিসপত্র, ইউরিন বেরিয়েছে, হয়তো কিছু বেরিয়েছে, soiled. You are cleaning it again. Firstly কি?
অ্যান্টিসেপ্টিক ড্রেসিং।
Dressing and draping. Number 2,
স্যার তারপরে ডাইরেক্ট করে স্টার্ট করতে হবে না, আবার ইনফিল্ট্রেট,
অবশ্যই।
তো ওটা তো করা ছিল,
কতক্ষণ থাকে লিগনোপেন?
আচ্ছা আচ্ছা, কিন্তু স্যার ওটা যে পেনটা হচ্ছে সেটা তো এই পেনটাকে তো ছাপিয়ে যাবে, তো অনেক সময় তো করেন, আমি
এটা কে বুঝিয়েছে?
স্যার এখানে দেখেছি স্যার, ইনফিল্ট্রেট না করে করেছে সেটা,
কে? এসব কথা বলিস না বাইরে,
আচ্ছা স্যার কেটে হচ্ছে না ইনফিল্ট্রেট
এসব কথা বলিস না বাইরে, বলছি তো।
আচ্ছা আচ্ছা
Not everything you see is not everything in the books you're going to practice.
আচ্ছা
Infiltrate again.
ইনফিল্ট্রেট
কাটার আগে analgesia, sorry anesthesia, repair এর আগে anesthesia, ঠিক আছে? Do not forget this. You are going to infiltrate again with lignocaine. Let it take you 5 more minutes. I don't care. Always give an anesthesia first. Every pain is pain. কোনটা বেশি কোনটা কম is not important. Always. Next.
So we do give the anesthesia again by guarding method. We will
আর গার্ডিং কি, কার থেকে গার্ড করবি? বাচ্চা বেরিয়ে গেছে তো। সিম্পল অ্যানেস্থেসিয়া। হ্যাঁ,
তারপরে স্যার
স্টার্ট রিপেয়ার।
so we have to start the repair. You have to see the apex of the cut which is over here. So 1 centimeter above the apex you have to give the knot. Then by non-locking pattern you have to
Continuous non-locking switches.
continuous non-locking switches. You have to repair the vaginal mucosa.
Okay.
Then we have actually 3 layers
Yes.
you are repairing it: the vaginal mucosa, the muscles, and the skin. So the in the muscle we have to do interrupted sutures, and in the skin we have to do the matrix suture.
Very good.
After that,
Yes, you clean it again with antiseptic solution and let the patient be. Okay. Any queries? কাটা। Where is my hand? See, your কোন দিকে তো সুবিধা, if you are going to give it like this, this is going to be easier for you. This part, left side, ঠিক আছে? If you are going to hold it like this, your right will be easier for you. কোন দিকে ধরবো তার উপর ডিপেন্ড করছে, ঠিক আছে? This scissors is universal. Listen to me. This scissors is universal. This is for both the right-handed persons and the left-handed persons. This can be held in both ways, like this, like this. Okay? You can do it in this way. আমি উল্টো আছি না, that's the problem. আমি এদিকে আছি। See, আমি উল্টো করেই দেখাচ্ছি, হ্যাঁ? You can do it like this. You can do it like this. You can hold it in both ways. Your left-handed person can do it like this also. See, I'm holding it. আমি এখন ধর পেশেন্টের সাইডে দাঁড়িয়ে আছি, ঠিক আছে? আমি এই দিচ্ছি ইনসিশন, আমি পেশেন্টের সামনে আছি, এই this. Is it visible? Always try, this has to go inside. Blunt end has to be inside.